All right, good morning, everybody. It's a great pleasure to see you all this morning to have and enjoy this upcoming discussion with Dr. Maria van Kerkhove, who will share with us some of her insight from the World Health Organization, experience based also from the COVID experience, but also other topics. So it's a great pleasure to have Maria today. She's a distinguished leader in global health, currently serving as acting director of the Department of Epidemic and Pandemic Threat Management at the WHO. And she has a critical role as a COVID-19 technical lead and emergency manager, and a global incident manager during the 2024 mpox outbreak. So she was trained, she holds a PhD in infectious disease epidemiology that she obtained from the London School of Hygiene and Tropical Medicine. She had experience worldwide in the US and in Europe, and over the last 2 decades, her experience in infectious disease epidemiology, she has led responses not only for COVID-19, but also Ebola, Zika, MERS, influenza, and mpox. So she's a strategic thinker, bridging research, policy, and practice, and she's widely recognized for her leadership in strengthening global health system and international collaboration. And so it's really a great pleasure to have you, Maria, today with us. And I will just end my very brief introduction and invite Maria and Jacques to come to the stage, and they will share with us a discussion on Is the World Ready for Another Pandemic? Thank you very much.
Well, thank you very much, Stéphanie. Thank you for being here on a Monday morning. No fire, sorry, but a fire chat, and a great pleasure to welcome you, Maria, and to take this opportunity, to take those moments to maybe take a step back and get a global discussion around public health issues in those uncertain times. So I'm a professor in the School of Life Sciences, but I'm also an infectious disease physician, so we come from the same background. And I encourage you to go explore infectious diseases because it can lead anywhere, as you can see. Maybe to start, I have my little cards here, but my first question, reading some newspaper this weekend, I read that WHO partners, countries, and employees didn't sleep much last week. So why don't you tell us what you hope to achieve and what has been done over the past few days at WHO that really shows the importance and the difficulties and the hopes of your work?
Thanks very much. Thanks for having all of us here. I have some colleagues here with me from WHO. And thank you for taking my giant picture down from the screen. I am still not used to seeing my face anywhere. But thanks very much for the opportunity to talk with you today and for coming this morning. So yes, last week was very interesting. It was the last week of what we call the INB. These are the member states that have come together to discuss the Pandemic Accord, the Pandemic Agreement, the Pandemic Treaty. And it was fascinating. So yes, there was very little sleep. This group of member states, 194 member states, in fact, in the room there were 192, discussing over 3 years an agreement, an international binding agreement related to pandemic preparedness, readiness, and response. Essentially, it's to have something better than a handshake, to say we're going to do better the next time, because there will be a next time. And not only will we do better in terms of response and looking at the equity and the distribution of medical countermeasures, but also in pandemic prevention and preparedness, working across different sectors, looking at multiple different types of pathogens in the complex world in which we live. So last week was the last week of negotiations, and it was quite intense. There were there was much more agreed than they disagreed on, but it was an intense week, and there was huge progress that was made in agreements across the different member states. We were sitting around 100 and lots of different countries, a full auditorium, until after midnight each night, And then on Friday night, which was the last day, we actually negotiated through the night, finished at 9 o'clock on Saturday morning. I think everyone was a little delirious at that point. But by the end of it, the member states agreed to almost everything. They agreed to everything related to pandemic prevention, preparedness, response, using a One Health approach. They agreed to this critical aspect of a pathogen access and benefit sharing system, which is essentially those who sign up to this system have access to information, sequencing, materials, biological materials, to be able to develop diagnostics, therapeutics, and vaccines. And in signing up to do this, they essentially agree to give a proportion of their product to WHO at donation or at cost, so that WHO can work on distributing these on an equitable basis based on risk and need. It's huge, huge, huge. There are still, it's not done. There were a lot of congratulatory hugs and pictures that were taken on Saturday morning, but it's not finished. So we come back tomorrow to negotiate a couple of remaining elements. And then, of course, it has to be ratified by governments. So it's far from over, but I'm quite hopeful. And this is really critical. It may sound, bureaucratic, but to be able to have more than 190 countries come together, especially right now, especially with coming out of COVID crisis, especially with the changes in the geopolitical landscape and the complete retreat from funding in global health, with many governments moving their funding from health to defense. This is important. So it's interesting. I have to say, some of the discussions were some of the most dull I've ever heard in my entire life, but kind of fascinating of just listening to them, because it's not just discussing health, it's discussing the legal aspects of how you do this. So that's what happened last week, and that's what happened Friday night into Saturday, so yeah. Oh.
Yes, indeed. Thank you. Who are the two countries that didn't show up?
So the U.S. wasn't there, which is not surprising. They've said that they wouldn't be there. And then there were a couple of countries that weren't. I don't know if Argentina was in the room. They've signaled their intent to withdraw as well. But there were a couple of other countries. So it depends. Not all countries are actively vocal, but most of them are. And then they operate in blocks. So the EU speaks together. There's the countries across the African region, plus a few others, speak together. And just listening to the negotiation of how they're saying, well, we'll give you this if you give us that. And I have to say, even in the toughest part of the negotiation, they were there in good faith. Every single person in that room wants to see a pandemic accord. How? And it's going to be imperfect. That's the only thing we can say, is that it's imperfect. It doesn't have every single thing that we want in there, but it's enough to really work on it, and it's enough to, make a difference in this, global interconnected world we live in.
Okay, so maybe that's the natural segue for the question I have here about the recent US disengagement, obviously, from International Health Initiative, from sanity in general, I would say. How does it affect global pandemic preparedness? In this room, US is not there, so does it mean that the discussions are kind of B-league, or it is still the world coming together and achievements that will be useful for humanity?
Well, I mean, the world is a big place. I mean, it's really a small place if you think about it, but we at WHO, and I've always said this, I feel like is one of our superpowers of bringing people together, bringing the best minds together to tackle the world's biggest challenges in health. And it's messy. I mean, it's messy, it's complicated, it's not just a technical issue. There are all of these other aspects that we have to discuss: economics, accessibility, acceptability, sustainability, to be able to implement life-saving measures. The U.S.'s withdrawal from WHO is an intent. So they signaled their intent to withdraw. They haven't left yet, and there are certain conditions in which they have to pay their assessed contribution to be able to withdraw. But we leave the lawyers and the politicians to deal with that. The biggest challenge I think that we've seen is threefold. One is the technical withdrawal from WHO and from other partners. So in the past, no matter what was happening geopolitically, the scientists came together. We're a bunch of nerdy, sciencey people who were never on TV, by the way. And we love what we do. And I think we're really lucky to say that we love this field of work. always come together, no matter who's in office in whatever government we're talking about, because the work that we do transcends, election cycles. So the technical withdrawal from the U.S. government agencies has been really abrupt. And it's significant because we have U.S. government scientists and public health professionals as part of all of our expert networks. Having said that, we work with everyone everywhere, and there's incredible expertise, including right here, that are part of our advisory groups, that are part of our expert network. So if the U.S. is not going to come to the table, there are many, many others who will and who are. And so the work continues. I hope they change their mind. I hope the technical exchange comes back, but right now we move on. The second big thing is that not just, and it's not about WHO, it's about the investment in global health. So we expected the investments in WHO to stop, but we didn't expect or anticipate the incredible stoppage of funds in global health everywhere overseas. So all of these programs, these life-saving programs, stopped overnight. And we had one estimate, and I don't know how accurate this is, so I don't know how we came up with it, but around 700,000 people in public health have lost their jobs since January, globally. These are people who work in NGOs, in CSOs, who are working on the front lines, who are delivering medications to women and babies, HIV medications, who are delivering care that's just stopped, and they've been let go. So even if the money comes back overnight, we still can't implement these programs in countries because the people aren't there anymore. And that was significant. And the third thing is just how quick it all happened. Again, we were anticipating these changes to funding, but not so quickly and so abrupt and so comprehensive. It's organized. And it's having a detrimental impact across the space. So it's impacting all of our programs. At WHO, we're about 20% of our funding comes from the US. The department in which I lead, I'm so fortunate to lead, is about 60% US government funded. And so we've been trying to diversify our funds for years, and we were in decent shape a couple years ago, but all of that money's gone. I mean, much of the money, certainly post-COVID crisis, but a lot of it went to Ukraine and to Gaza, and now we're seeing a further constriction in funding for health. So there's a lot of different aspects, but the pathogens we work on really don't care, and in fact will exploit the situation that we're in. So we're fully focused on what we need to do. It's just becoming harder.
Yeah, so we all agree what US does is bad, but for me it raises also a question of how much we relied on the US. So it's kind of nice for us, Swiss citizens or European citizens, to say, oh, the US stopped PEPFAR and millions of people in Africa will be in bad shape or die. But that means that the US taxpayers were basically paying for Africans not to die from AIDS and not us. So how does that reflect on what was the situation before, where the US has this disproportionate influence on public health in the world?
Yeah, so there's a lot of discussion about that right now, and the over-reliance on one particular country, one particular donor, if you will. And will other countries step up? I mean, that's the challenging space right now. There's certainly a desire, there's certainly a want from countries to do this, but they're honest with us, and we respect this, right? COVID changed everything, and there's always enough money for defense, let's face it, right? And the operating budget of WHO is less than one hospital in a high-income country, less than one. And so we're not talking about huge amounts of money, and money can be found. But given what's happening, I think, globally in the push towards defense, it's really quite scary. We're trying to change the narrative that health is defense. There's the global health security, but will other countries come forward? Many of our other donors have said we cannot make up the gap for the US, and they shouldn't have to, but we need to diversify, and there needs to be more of an investment. WHO has been talking about this with our member states and the assessed contributions from member states, but also voluntary contributions. And we need to have much more flexibility in the money that comes to us to use it where it's necessary, as opposed to someone saying, we'll give you money if it's only highly specified for one list. WHO, with our member states, together with our member states, should decide what are the critical activities. And in fact, that's what we're doing right now, is reassessing all of our priorities. Because given the global situation that we have to not only say what our priorities, but we also have to deprioritize certain areas of work. And our DG has made it very clear that across the entire organization, we will be making about a 25% cut in staff. And that's going to happen, before May, at least making those decisions. And these are people, that work day in, day out, blood, sweat, and tears, and like all of you, love what they do. So it's very, very difficult times, I think, for everyone.
Any place there for private donors, philanthropy, or would that be a bad idea?
So we have established the WHO Foundation, which is going towards private donors and non-traditional donors, making sure that we follow all the appropriate rules and whatnot to ask, to go to private, independently wealthy individuals and different types of foundations. And we have raised some money through this, not as much as I would have thought, to be honest. But it's about how we sell health, if I'm cynical. What are we selling here? Are we selling health? Are we selling saving lives? Are we selling saving livelihoods? Strong economies are based on healthy people who contribute, who work, who buy, who, and we learn this obviously during COVID. We learn this after every outbreak. It's not just about health. It's about, your livelihoods. It's about the societal impact and the economic impacts that these outbreaks and these pandemics have. But we need to do a better job of selling, if you will, what we do. And prevention is not as sexy as response. So we always are able to raise money in critical, Myanmar earthquakes and situations like Ukraine and Gaza. But it's very, very difficult to raise money for prevention, And we look at COVID, and we had one estimate, which actually came from 2020, of $16 trillion economic loss. I actually wrote to the author a couple of weeks ago and said, have you updated this? And they said, no, due to funding, we didn't update it. So it's probably even more than that, but $16 trillion loss for one, pandemic, which was bad and really bad, didn't need to be as bad, but it's actually not the big one. We know there will be a flu pandemic. We know. We don't know when. We don't know where it will begin. We don't know which subtype, but it's going to happen. And then there could be something else. And so for me, when people, don't even want to talk about COVID anymore, they want to pretend that it didn't happen, that's extremely detrimental. Not only did you have an economic loss, we've had at least estimates of 20 plus million people died, 1.6 billion children out of school at one point. How many kids didn't go back? How many girls across the world did not go back to school? 135 million more people pushed into poverty. So if you have more humanitarian crises and geopolitical crises, people needing humanitarian assistance, anything that spreads, anything that's novel is going to have a worse impact. So it's quite a difficult space that we work in, not only from a technical point of view of trying to answer those questions of what is it, how's it spreading, but how are we actually going to mitigate its impact?
Oh, yeah. So going back to COVID, you mentioned some numbers that we should remind people more of. But from a public health perspective, what are the lessons that were learned and where we are in better shape now thanks to the COVID experience, if any?
Yeah, so quite obviously a lot has been learned, continues to be learned, continues to be applied. Some of the things, if we think about from a scientific point of view, some of the things that we learned is the critical importance of collaboration. These are not new learnings, right? So nothing that I'm saying is a new learning, but the critical importance of scientists coming together. Again, in the beginning of COVID, within the first couple of hours, we had clinicians talking to each other from Wuhan and from Riyadh, because in Riyadh they were dealing with MERS patients, and in Wuhan they were dealing with this pneumonia. We knew it was a coronavirus very early on, but what were you seeing, what were you doing? That ability to bring people together and acting fast, using the systems that you have, whether we're talking about capacities for contact tracing or for surveillance or for border controls or for screening or for clinical care, for emergency operations, whatever capacities you had, utilizing that in the beginning really put some countries on better footing. Countries that had experience with SARS, with MERS, with avian influenza, knew the warnings that we were putting out were serious. We were not, you don't call a public health emergency of international concern over nothing, right? And the warnings that we were giving people listened to right away. We learned the importance of investment in research. So our R&D blueprint for epidemics in 2017 set up priority pathogen list, and on that pathogen list were coronaviruses. We had MERS coronavirus. There had been some research that was done on SARS and on MERS, the development of target product profiles for coronavirus diagnostics, but also quite a bit of work on vaccine platforms, the technologies that existed. There was work before that on mRNA technologies. That investment really paid off because when the sequence was made available, they hit the ground running in terms of the development and looking at the preclinical trials, the clinical trials, and actually within a year, starting to administer vaccines, a highly safe and effective vaccine, which was no guarantee. We look at the critical importance of prevention, and what work is done on prevention, and that's just getting systems ready, getting sectors to work with each other and to communicate with each other. So many. So, I mean, we can spend the next hour on all of that, but the question is not just what you learn, but how are you applying? So what we've done is looking at, let's take vaccines, for example. So not only safe and effective vaccines, but looking at tech transfer. So there's been some advancements on tech transfer. There have been some advancements on the development of mRNA hubs in countries that are not just high-income countries, but in Africa, in Asia, to be able to have production increased. There's quite a bit of work that's happening on sustainable financing with the Epidemic Fund. And so far, more than $400 million has been administered through the Epidemic Fund to more than 40 countries, looking primarily at surveillance, at workforce, on laboratories. So there are concrete steps that have been taking place. We have the BioHub we mentioned earlier today about pathogen sharing. So essentially before COVID, we had one global system to share pathogens and only for influenza. So Dimitri, my colleague, is here from the Global Influenza Program. The Global Influenza Surveillance and Response System is a network of more than 150 national influenza centers, WHO collaborating centers that do surveillance for flu, that share samples, that risk assess those samples, that identify candidate vaccine viruses to share with manufacturers so that they know which vaccines to produce should we have a pandemic. We only have that, and we have a pandemic influenza preparedness framework for flu. For everything else, we essentially have to set that up each time. That's why the pandemic agreement is so important. And one of the things that they've agreed to, again, still not finalized, is a pathogen access and benefit sharing system for pathogens with epidemic and pandemic potential so that we don't have to set this up each time. These are significant improvements. The question is how well they will be implemented in country and will they be financed?
So that's part of a global surveillance system. Your mission, the mission of your team is to basically detect emerging pathogens and make sure they don't end up being pandemic.
Detect, prevent, respond. Yeah.
So what's still missing, or what would still be missing after this new agreement for the global surveillance system to make it really the best possible tool to prevent the next pandemic?
I mean, having an agreement in place is an important one, but implementing that agreement is something completely different. By the time it gets ratified and we are actually using this agreement, it's going to be years. It's going to take some time. So in the meantime, we've set up systems. We have WHO-coordinated laboratory networks that are looking at how do we get labs to talk to each other, how do we improve surveillance for the earlier detection. During COVID, PCR capacity expanded massively. Obviously, that started before COVID, but this was a massive accelerant and catalyst to really get the capacities we need in country for PCR, for sequencing. And at one point, we had 94% of member states able to do genomic sequencing. Prior to COVID, most of the time the pathogen was identified in one country, sent to another country, and the sequencing was done there. We've, in a sense, democratized that in many ways. But we need stronger surveillance in animals, at the animal-human interface, strategic surveillance for particular pathogens. And the way that we look at these is through respiratory pathogens, so the influenza viruses, the coronaviruses. We're looking at arboviruses as a whole. We're looking at bacteria, epidemic bacteria. We're looking at the high-threat pathogens. And how do you make sure that countries are aware of what might be circulating? Not what is circulating, but what might be circulating. And climate change is changing this. Where these vectors can thrive. It's moving much further north and much further south of the equator. You have changes in which we're living on this planet and how we come into contact with wildlife and with forested areas, market systems. And so the surveillance aspect, that detection aspect is really, really critical. And it's scary right now because no country really wants to find the next pandemic virus. So politically, you know, we've done some workshops globally of looking at surveillance in wildlife, and what you see is reductions in funding for labs and for surveillance systems in wildlife. At the animal-human interface, you're seeing threats on those labs, not just financial threats, but personal threats to individuals. And governments don't want necessarily to publish this information because of the blame game. So what we're trying to discuss is that the collective interest that we have. No, these pathogens don't really care about your political affiliation or your borders. So you find something shows up somewhere, it's going to be on the other side of the planet in 24, 48 hours. So there is a collective interest, but what's happened certainly with COVID origins doesn't help that. And the blame to governments, it's a deterrent. So it's not just the capacities, but it's also the environment in which we work to be able to facilitate that type of work to continue.
So can you walk maybe us through what happens concretely when a government ratifies a treaty and then they are supposed to do the work to make it happen, right? WHO is not the conductor saying you do that, and having the workforce to actually implement what is in those treaties.
Yeah, so I mean, I don't know exactly the steps of how it's going to play out because it's dependent on the member states to be able to do that. Having said that, WHO is the secretariat of 194 member states, and we do what the member states advise us, and they meet every year at the World Health Assembly, which happens every year in May. In a couple of weeks, they're going to be coming into Geneva to discuss what we do. We have a program budget, we have a global program of work, which look at, you know, the critical work of WHO. We support member states. It's the sovereign states that decide what to do. One of our core functions is developing evidence-based guidance, strategies, programs to support areas around surveillance, for example. We don't tell countries what to do. We don't dictate what countries can do. We don't go into any countries that they don't want us in. We operate through our regional offices. We have 6 regional offices. We have 150 country offices working with the governments, supporting the governments in the implementation of all of this work in the space of global health. But one of our core functions is around evidence-based guidance, let's say, on clinical management of COVID, for example, or on, you know, the use of public health and social measures, which we didn't have prior to COVID. We're actually working on that now. And then the policies that are set by government are up to the governments to do so. So we support through ministries of health. We work across different sectors with our partners in the animal health sector, the environmental sector, certainly using a One Health approach for surveillance, for example. We do a lot of trainings, but again, it's to have that capacity in country. And then, of course, on the communication side of things, we work on misinformation, disinformation, infodemic management, because it's really quite messy out there in terms of the information. So lots of different ways, but we don't tell countries what to do.
Which might become a problem if we imagine a world where governments tell you that misinformation is not misinformation anymore. It means that WHO could become the vehicle of misinformation, or am I pushing the needle too far?
No. I mean, I think our job is to ensure that the data, you know, the data that exists, that is turned into know-how, and that know-how is turned into how-to. And we do that through a robust mechanism. Not all data, not all studies are the same, even published in high-impact journals. You know, we do a quality assessment of each of the papers. We do systematic reviews. We look at particular questions. Even when we develop guidance, we use a multidisciplinary approach. Sometimes we work with patient groups. We work with youth. We work with many different people to develop that guidance because if it's not implementable, it's useless. And what we try to do is when we speak, we try to address misinformation. We try to address falsehoods. Disinformation is something very, very different, that willful use of false information. It's incredibly powerful. It kills faster than viruses. And we just have to be consistent in that. We're also working to make sure that governments and institutions, national institutions, whether they're from ministries of health or they're the CDCs or public health authorities equivalent, are also out there communicating. One of the things, I just saw a paper recently, and we talked about this a lot through COVID, is that many scientists did not speak out during COVID. you know, and those of us who did, and this was not my job during COVID. It was not, I didn't think I would ever have to do this. I'm very privileged to do it. But the attacks on scientists, and I actually expected many, many more of my colleagues to be out there saying, that's rubbish, like this is just not true, or this is how we develop this, our understanding, and this is why it's changed, and this is what is uncertain and why it's uncertain, because science is imperfect and it's a process and you learn and you change. But so many people didn't speak out because of those attacks. And it wasn't just the noise, it wasn't just how loud people were, it was just how toxic it was. And I think that has to change. Not everybody should be out there talking, I'm not saying that, but we do need a collective voice, and that will address some of this misinformation. That will address some things that are fact and truth and science. Science is a process. People would say to me, when's the science going to be done? Could you just stop? Could you please just be done and just say yes or no? And that's the other thing. It's these false dichotomies of yeah, all or nothing, everyone in a mask, nobody in a mask, you know, everything is locked down, nothing is locked. I mean, and none of that worked, none of it worked that way. And we've made mistakes. I've made mistakes, but we were up there every single day trying to correct and trying to answer. And we need more of a collective voice that's out there to back each other up, because quite frankly, that's the only way we're going to get through that next one.
Yeah, and so what is a bit depressing is that we are in a world so polarized that there is the camp that is now anti-science. So being on our scientific background, scientific process, explaining all that, how do we reach the other half or the other fraction of the population that is strongly anti-science now? Is there a way, or should we just renounce and make sure our audience is happy with us?
No, I think if you're only talking to audiences that are happy with you, then you're doing a disservice. I absolutely think that there's a way. You know, I think we have to explain better what we do, and a lot of what we do is so highly technical, it just doesn't reach. It's not approachable. And I think we have to communicate in a way that you're talking to your kids, you're talking to I was always, in the beginning of COVID, I was always talking to my grandmother. It's so funny, because I'm not trained in communication, and you're supposed to have your SOCO, your one message, your one audience, but every time we were speaking, it was to journalists, it was to politicians, it was to general public, it was to children, but it was also to the expert people in the field. So, but I remember I was talking to my grandma Pee-wee. She was my one person. She was not alive during COVID, but she was my one person to explain something to, of like what. So we don't make it accessible. But I also think we need to kind of, in ourselves, be quite a bit more humble and have some humility in how we are explaining these types of things. Answering questions about what is this vaccine and why do you need to give it to my kid is not the same as being anti-vax. To say, how is it developed? What's in it? What's it going to do? What are the side effects? How do you know? You know, and what's the risk to my child based on, you know, or my grandparent or myself versus what, you know, that pathogen can do to you are legitimate questions. So negating those or to put those down in a way really doesn't help. So a lot of what we try to do is we try to get to the point of what's the actual question you're asking. You know, what is the, and I did my first interview on Fox News the other day, which I'd never ever thought I would do. I did not want to do. But talking to people who really are anti what you are and just having an opportunity to answer some of those questions, I don't mind them. People didn't want it. They're like, well, you're anti-airborne. I'm not anti-airborne. But they would not want to ask the question. Ask the question. We'll talk about the question, and we'll talk about why it's so hard to talk about the question. You know, I think we need to do much better. But if you're only talking in rooms of people who support you, then I think we need to have a bit of a thicker skin here and really, really be challenged, because that is what science is after all, right?
Yeah, remind me of a meeting with GastroSuisse president during COVID. I was in the task force with several of us here. And the guy was the anti-science because he wanted to keep the restaurants open. And after an evening with some good wine from Valais, The guy said, but after all, you seem human. And I was, yeah, we should talk more, actually.
Everything is better with wine,
yeah,
is the moral of the story
that's
here.
the message.
Yeah.
So maybe let's just tackle something you mentioned briefly, and then we'll open questions for the for you guys. So climate change and how it impacts your work and how it will impact the future of public health. What does it bring?
I mean, it's happening now, right? So it's interesting. Sort of after COVID crisis, everybody said, okay, we're done with pandemics. We're going to move on to climate crisis, as if they are distinct things. You know, so they're interconnected, absolutely interconnected, and we're seeing the effects on it now with El Nino, La Nina. We're seeing it with mosquito vectors, and right now, you know, 4 billion people on the planet at risk for chikungunya, Zika, yellow fever, dengue. That's going to go to 5 billion, you know, in the next couple of decades, if not sooner. We see changes of wild bird migratory patterns in terms because of freeze-thaw cycles of, you know, this massive epizootic of avian influenza. There are challenges with different bacteria that we're seeing with animals and with ticks, you know, looking at how animals are raised, how they have to migrate to water. So it's happening already. And we're not only seeing it in the infectious disease space, we're seeing it in the humanitarian crises as well, in the climate-driven humanitarian crises, with people being displaced and challenges with water and cholera. And so across the board, not only is it increasing the risk of infectious diseases and spillover and the geographic spread or distribution of where these pathogens can emerge, but we're also seeing sicker people, or people who have less access to health care, people who have more need. So again, whatever is circulating is going to have a worse impact. So we're working very closely with our colleagues with climate, and trying to make sure that this narrative is not we're done with pandemics, we move on to climate. It's all interconnected, but also being smarter with how we describe it and how we talk about it.
Okay, so there are 2 microphones at the end of the 2 aisles here, so I invite you to come and ask your questions, if you please. Yeah.
Thank you very much. Very, very interesting. I would just lift it so I can stand properly. The preparedness is, of course, partly medical, but to a large part, it's not medical at all. It is what kind of resilience we have in society, how excessively or not globalized we are, what kind of local stocks we have, how unequal the society is, what is the general level of health of people, what's the general level of knowledge of the population. All of these things probably would have made an even bigger difference in the number of dead people of COVID, and even more in a future pandemic. Can we do something about that? And can the World Health Organization do something about that?
Yeah, absolutely. So thanks very much for the question, and thanks for shaping that. We are looking at threats in different ways, and pandemic preparedness in different ways. We have different lenses, we say. And one is sort of governance and systems and financing. One of them is around the threat specific, what we know, you know, the known pathogens and the novel ones. And not only from a biological risk, we also look at laboratory biosafety, biosecurity, and Nikki is here with me who leads our work on that. And not only from an accidental release, but maybe from a deliberate release. We look at preparedness and prevention from a capacities lens. So looking at community protection, and what does that mean for a community in terms of their ability to not only protect themselves or have governments support their protection across different types of capacities, whether we're looking at safe and scalable care, we're looking at infection prevention and control, we're looking at risk communication, community engagement, we're looking at the general health and well-being and access to primary health care across that entire landscape, but also from a response side of emergency operations. How well can they pull together the different sectors to deal with different types of crises? How ready is it? You know, a lot of countries had emergency operations centers that they never used before COVID, and now they've used them for COVID, but they're using them for earthquakes, they're using them for cholera. It's a system that's there. Looking at collaborative surveillance across multiple different sectors, looking at medical countermeasures, and not only what exists, but the R&D, the entire end-to-end spectrum of research and development. So we've moved from a priority pathogen focus to looking at pathogen families. So there's a whole work on the R&D blueprint for epidemics that are looking at key priority pathogen families with prototype pathogens for diagnostics, therapeutics, and vaccines, and trying to get ahead of what the next one might be. And it's a change. We also look across the emergency cycle. So before, WHO used to have a preparedness division, a response division, a surveillance division. We no longer have that. On the one hand, it was a good thing to have because there was attention to prevention and preparedness, but on the other, nobody works on prevention versus response, right? So you have to look at that whole thing. And then you also mentioned resilience. So across that whole landscape, we have areas of work that are either sort of vertical, and when we look at sort of the threat lens, but also horizontal in that matrix style of capacities, but working across different sectors and making sure that not only are we dealing with an acute crisis, but we also make sure that the essential medical services don't stop, which of course we saw during COVID. So it's quite complex in how we do that, and frankly, we have to do more with less. We have to do all of that with the geopolitics. We have to do all of that with less financing, and we have to do all of that with less people. So, but it is complex. It's a complex ecosystem. You know, people are saying polycrisis. There's all these great words now, but nobody works on any one thing alone. And even within WHO, we're trying to cover this across different lenses.
Thank you. Please.
Hi. So the United States has had a major foreign policy shakeup when it comes to health, but it's also had a domestic policy shakeup in the sense that the Health and Human Services is now led by what's essentially a vaccine skeptic. Mm-hmm. If the next pandemic starts in the United States, is the WHO and the medical community at large, worldwide, prepared to deal with an emerging pandemic that starts in a country that's entirely not collaborative with it?
You have quite a bit of layers in that particular question. I think, let me focus on the positive. So yes, the US government has indicated its intent to withdraw from WHO as a member state. The government institutions that are there still contain incredible people that work there, many of whom have been laid off and fired, which is really, really tragic. And of course, we discuss globally what's happened related to that. There are many, the US still reports through the international health regulations, so they're still reporting cases of avian influenza, for example, through IHR, through their focal point. That's a good sign. Many states in the US have reached out to us, to WHO, to PAHO, to say, how do we do more? Even if the US government has withdrawn, how do we continue to contribute? And there are many systems in which governments or states can contribute. So if they share sequences, you know, with GISAID, for example, or other publicly, but that's an incredible, that's good. And states are still doing that. That's important, especially for like the global influenza surveillance and response system that is constantly monitoring circulating influenza viruses, because every 6 months, WHO has to make recommendations for vaccine composition for the next season in the Northern Hemisphere, Southern Hemisphere. So there are ways in which the US is still contributing. The technical shutdown is really just tragic because we know our colleagues want to talk to us, they just can't. And they're really afraid to do so because they could get fired. If there were to be a pandemic that would start in the US, and that's very possible, especially with avian influenza that's happening right now, I do think that we will get some information. There's still a free press in the US, but let me also state that there are many other countries that aren't as transparent as we would like them to be. And part of the international health regulations is around this sharing of information, and this is international law about the detection and the sharing within 24 hours of certain types of pathogens. And it gives you the person, place, time, the case, you know, the exposures that we know about, any, you know, work that's done, or signs, symptoms, contact tracing, sort of the extent of that cluster, whatever that signal might be. But there are varying levels of transparency of our member states. We would like that to be improved across the board. But I think if there were to be a pandemic that would begin tomorrow, we would handle it. Would we do it to the best of our ability? Yes. Would it be to the best of the ability that everybody deserves? Maybe not. But it won't stop us from doing everything that we can to inform, to risk assess, and to share information as quickly as possible so that governments can take decisions to keep their people safe.
Thank you very much.
what are you saying to all those who want to use natural medicine to boost their natural immunity? And do you include in your researches actually as well scientists who make researches about the natural defense of the body and the system? Mm-hmm. Do you include also those data?
Thank you for the question. So yes, I mean, in not necessarily as a responsibility within my area of responsibility at WHO, but certainly there are those at WHO that are looking at all different types of evidence and looking at natural. We have traditional medicine centers. There's one that's opened up in India, if I'm not mistaken, of looking at that, looking at Western medicine, looking at Eastern medicine to see how you can improve the health of the individual. What we're trying to look at is the whole person, the whole community, the whole society, and looking at what makes people healthy, whether it's from a medicinal point of view, you know, from medicines that are, and I know there's a lot of advancements in terms of therapeutics, but also in the physical well-being of the person, the mental health of those individuals, and there's a huge expansion of work on mental health as well, and looking at the environment in which people are working so that they can thrive. So I don't have all the answers to that particular question, but yes, there are people at WHO that are looking at that.
Thank you.
Hello, thanks for the discussion. I just wanted to ask that as we saw during COVID, a lot of countries used scientific information for pursuing their personal political agenda and spread a lot of misinformation. And as you said, that WHO doesn't actually go inside the countries and dictates what everyone should do, but how does WHO ensure that during these sensitive times, like during the pandemics, the medical and scientific information is not misinterpreted and not misspread by the government?
So a couple of different ways. I mean, part of our norms and standards is around, as I said, this evidence-based guidance, and the development of those is very, very robust. We have to accelerate the development of that during crises like we saw with COVID. But even when we issue something, we're constantly looking at the latest data to update it. It's always in a constant state of revision. We work with the governments to look at their own policies, but there's huge difference between evidence-based guidance and policies that are set based on the evidence that governments choose. So during COVID, we saw quite a lot of countries, you know, if we look at even just the isolation period, for example, as an example, the data is the data, right? We know how long people, and we learned this obviously, which changed certainly from the early days to on how long people were infectious and how long an isolation period should be, with a goal of not preventing onward transmission. That's very, very different than a policy set to say isolation is going to be 5 days or 7 days or whatever, because we need people to get back to work. And the risk at that 5 to 7 to 10 days is much, much lower, and we need grocery stores to be open, or we need certain essential functions to persist. But the problem with that is, like, when some countries would announce this, they would say, well, the evidence is different. You know, and the evidence says 5 days or 7 days versus what WHO is saying 10 days, which is a disconnect, because we're all looking at the same data, and that really eroded trust in scientists. So what we try to do is be very clear about what the data says for the intended objective. So there's a lot of work right now that's happening on the use of public health and social measures. Before COVID, we had very little, if anything, which I'm still angry about, I have to say, because we've had decades of flu and we didn't have the kind of data that we want. Even masks, we only had a few studies that would look at this in observation, and they're poor. But to be able to give the guidance that people wanted in January and then through the months was really lacking. But the use of public health and social measures, for example, now we're looking at this huge body of literature to say, what can we say in terms of guidance for the intended consequence of preventing spread without having the unintended consequence of economic impact, societal impact, mental health impact? And that's a challenge. The only thing that we could do is to communicate often, to communicate uncertainty, and be honest about what that is. But not only say we don't know, or we don't know yet, but here's how long it will take us to find out, and here's what we're doing to find out. So it's a constant dialogue. I don't think there's a one-off answer of saying, we will give that answer and then move on. So I think it's a constant struggle and a constant battle for us, but we will have to deal with misinformation for the foreseeable future.
Yeah, thanks a lot.
Hello, thank you very much for the talk. I have a question. We are a university here, and a lot of things that you said were about that we need to be better in communication, communicating with different stakeholders, different perspectives. Do you think that, let's say, we as a university in general, not EPFL, but as academics, we are doing our job on having students that leave the university that are not only trained on the technical side, but that can be the connectors and talking to different fields and explaining things in a simple way?
I think so. I mean, I think the work of academia globally it's just incredible. I mean, just the new generations coming up through this and really thinking innovatively and teaching science and teaching weight of the evidence and really understanding that it's not just one experiment, it's not just one study, it's just the collective, is such a skill set to have. I do think curriculum really does need to cover certain aspects of communication. I think the networking that's done in academia is absolutely critical, because when the next one happens, it's based on who you know and the trust that you have within them. So students should be networking and collaborating as much as possible. And no matter what students are doing, you never work in only one discipline, ever. I don't think you should. I mean, maybe a lab is a little bit different. Maybe I'm speaking out of turn, but working across different disciplines, certainly to tackle some of these big challenges, that's where that magic spark actually will happen in terms of advancing something and turning something that from basic science all the way in through public health. So I think academia is a really important incubator. Sorry for the word, you have incubators here. To be able to generate, and I do think, for our expert networks, we have a lot of the top people in the field, professorial kind of level, but we also have, junior and mid-career staff and scientists that are joining and are really kind of kicking the tires to say, why are you doing it that way? Things have changed, and certainly with technology, we were talking earlier today on technology can leapfrog what we used to be able to do. So I think what you're doing here in academic institutions really hold tight to that. I'm really scared of what's happening within the US in some of the universities and the withdrawal of funding. The independence of universities and of what you're doing with these students is really critical for not just now, but certainly into the future.
But to take something back from this, I think maybe we are doing stuff, but maybe we are not telling the students what we are doing and what's the intention. Maybe this is something that we can integrate a little bit more to be conscious about. Yeah. You've been training this, you've been networking as a student, Absolutely. You've interacted with people from different fields, because I think often my students, they are not aware of this. It's a little bit hidden.
Yeah, I think that would be great. I think that would be a real added benefit for them. Thank you.
Yes, please.
Hi, sorry. I had a question with regards to this crisis in confidence, which obviously we saw all happen during COVID, mistrust in our institutions, mistrust as well in the healthcare professionals who themselves had questions and who didn't feel like they were listened to because they're not scientists, but they're clinicians, they have experience on the field, they're treating the patients and they're testing what works, what doesn't, because in a crisis, you do what you can. Yep. My question is, what is the WHO or even the EPFL or institutions in Switzerland doing to help rebuild that so the next time that there is a pandemic, these voices can be heard? Because I get concerned when you say that someone who wanted to close his restaurant you consider anti-science. But then we look at all the damage that we've done on a society, on an economic level, on a mental health level. We need to take that into consideration as well. So that my question is what can we do next time to make that better?
Yeah. You want to answer the Switzerland question? Please.
No, I think it's better if we listen to you. But I think here, an advantage of the Swiss response at the science level is that it incorporated different corners of science or society in the task force immediately, and the task force was only consultative. But it's, as opposed to many surrounding countries, we had from day one in the task force representative from education, psychology, political sciences, and that was a huge boost to interdisciplinarity and to a council that was not just oriented towards saving life at any cost. And I think it was reflected in many of the documents, so it has been exaggerated by some circles that the task force wanted only to focus on health or saving old people at the detriment of everyone else. I think it wasn't an accurate description of the actual recommendation that were made to authorities. But it is true that it's a temptation because it's easier as scientists. We know our 0-1, our interpretation of hard facts, and it's easier than projections on societal issues that we're not used to. Hence, the necessity to always discuss with everyone involved in society. But that's the Swiss experience.
Yeah, we tried to listen to as many voices as we could. I mean, certainly when we're developing the evidence-based guidance, there's a portfolio of expertise that we bring together, multidisciplinary, including clinicians, including frontline workers, including not just from high-income countries, but a diverse experience in terms of the globe, in terms of economic. Think about healthcare facilities and what they look like globally. Even within countries, right? There's quite some difference. But what we also did is we brought together different groups to discuss a lot of this. So through our risk communication, community engagement, there's a lot of work with CSOs, with NGOs, because these are implementers. These are people who are embedded within communities, that are working with the communities, that know the communities. We worked with faith-based leaders. We worked with different healthcare associations, whether these were the Council of Nursing or whatnot, but basically to talk about the policies or talk about the guidance with the consequences that we wanted to have, the policies that were set, why they could be implemented, why they couldn't, and listening, not just talking to, but listening, and have that iterative process. And then, of course, the communication coming out of it around whatever that guidance was, which is always written way too technical, really, really technical. We're trying to work on that to make it more accessible. So if we were talking to a government, we were talking to a doctor, we were talking to a teacher, we were talking to a parent, how it could be applicable for them. But we tried to listen to as many voices as we could. We're trying to do better at that. And youth as well. So they came to us in the beginning and they were just like, hey, a lot of, if you remember in COVID, a lot of the youth were blamed for the spread around, well, they don't care, they just want to go to parties, right? It's just so flippant, and that, young people didn't have the responsibility or want to take that responsibility and be part of the solution. So I think there's a lot more we need to continue to do in this space. But we do also have to come to a point of saying, this is what you need to do to be able to accomplish the following. To implement that, it's a whole nother thing. So working with economists, working with politicians, I would love to see a whole science of. Is that like an evacuation or something that we need to work on? No. Just working with others to be able to discuss how policies are actually set is very, very different, and governments have many different responsibilities. Leaders have many different responsibilities to keep those restaurants open or whatnot, to keep the livelihoods going.
Sorry about the Swiss precision in terms of interruption. It was precisely noon, so time to wrap up and close this session.
One more. Can we do?
Oh, yeah, one more question. Okay, sorry, I didn't see you. Please.
At the time, COVID took us by surprise, and you've mentioned some governments, or at least political agendas, are trying to forget that time of our history already. And I was wondering, how does WHO cope with that? How do we avoid an oversight that would cost us, the next time a pandemic just happens to us?
Yeah, we have a bit of a collective amnesia right now for COVID. Partly because it was so traumatic for everyone, and we want to be able to move on and say we got through that. And what we've been doing is we've been working with governments and looking at how they've moved from crisis mode to longer term, How are they incorporating COVID into respiratory disease surveillance, into infectious disease surveillance? What are they sustaining? What are they not? How are they doing this? And even the organization of their institutions. So many have set up CDCs or public health authorities within their governments themselves and adapting that. How are they dealing with the financing? But for us, things of this pandemic accord is a perfect example of, we're not creating a pandemic accord for the next COVID. It's for whatever that next one might be. And a lot of people in that room are thinking COVID, 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 how that started and how it unfolded. But it could be something totally different. It could be arboviruses. It could be something we haven't even thought of. So getting that commitment in a legally binding instrument across all of these member states, looking especially in this geopolitical climate, is a real commitment. But it's very difficult, even internally. Many people are like, okay, you had your time, we're moving on to something else. But the threats that we face, I think it's our responsibility to make sure people don't forget, not put it in your face and have it all the time, but really take those collective learnings. Like I said, one of the things we learned is act fast. The experience that we had with others put you in a better situation. Well, now everybody's had an experience with COVID. What are we actually doing to keep that up? It's not really a health question because people in health get it, but it's beyond that. But we also need to reinforce our workforce. We've lost a lot of workforce of medical professionals and nurses and from COVID, not only because they died, but at least a quarter of them have PTSD. And so there's a lot that we need to rebuild from that time. So again, a lot of people, I was talking with you guys on the way over, I'm giving a commencement speech in a couple of weeks for a school of public health at Georgetown, and it's like, what do you tell students right now? But I really, really feel you're in the right space. I really feel that this area of work is absolutely critical. I'm waiting for the revolution of like all these groups coming together to find new ways to be able to, deliver on what we believe in. But we'll keep at it and we won't give up.
Yeah, because it's not a question of if, it's a question of when, right?
Yep.
So that's not extremely positive outlook, but it's a realistic one, and we are fortunate enough to have people like you leading the charge. So thanks very much everyone for coming, for your participation, and it was a pleasure and privilege to host you. Thanks again for
so much.
coming and
Thanks
talking
everybody.
to us.